right. Good morning, everyone. It's lovely to see in-person faces. Welcome to those who are joining us on Zoom this morning. I'd love to have you join me in welcoming Dr. Alexander Bazazi to Grand Rounds. Dr. Alex Bazazi is an assistant professor of clinical psychology in our department at UCSF. And he is also the director of research and evaluation, assistant director of research and evaluation in the Department of Psychiatry and Behavioral Sciences at Zuckerberg San Francisco General Hospital. He earned his bachelor's in philosophy from Boston University, followed by an MD from the Yale School of Medicine and a PhD in epidemiology from the Yale School of Public Health. He completed his residency here at UCSF in the Adult Psychiatry Residency Program and through the Research Resident Training Program, the RRTP, along with completing psychoanalytic psychotherapy training at the San Francisco Center for Psychoanalysis. As a psychiatrist and epidemiologist, Dr. Bazazi leads research at the intersection of substance use, mental health, HIV, and the criminal legal system, with a focus on harm reduction, health equity, and systems level change. He has authored over 40 peer-reviewed publications and leads multiple grant-funded projects supported by the NIH, CDC, and Department of Justice. These include initiatives to prevent overdose from unintentional fentanyl use and to improve access to and outcomes of methadone treatment. And Dr. Bazazi works in close partnership with the San Francisco Department of Public Health, serving as a research scientist at the Center on Substance Use and Health and as a technical advisor on overdose epidemiology. He also co-directs the city's first overdose fatality review process and contributes to several public health initiatives targeting vulnerable populations. He does all of this, plus clinically, he provides care in outpatient opioid treatment programs and leads the HOPE post-overdose response team at San Francisco General Hospital. And no surprise here, in 2022, he was the recipient of our department's Public and Community Service Award. So needless to say, we are delighted to welcome Dr. Bazazi today to share his important work on unintentional fentanyl use.
Thank you so much, Rita. Thank you. It's nice to be here and down on the stage. I've been up there since it opened as a resident. I'm excited to share with you some of the work that I've been doing locally on unintentional fentanyl use. I have no conflicts of interest, and a lot of this work was supported by a RAP grant, an OUD RAP grant. So I'm going to be talking a bit about the clinical context, how I found my way into these questions, some of the epi, and then we're going to talk about prevalence, pathways, and prevention of unintentional fentanyl use among people who intend to use stimulants. A lot of people to thank for this work. As I'll share, a lot of the sort of inspiration is coming from seeing patients on our HOPE post-overdose outreach team. And I want to call out in specific some trainees who spearheaded big aspects of this work. So Patrick Lowe is a current UCSF medical student, incoming psychiatry resident here. He led one of the first projects I'm going to talk about, and Bryson Gomez is a current medical student in the JMP program, the joint UCSF UC Berkeley program. Lots of other folks to thank. And I snuck a baby photo in there along with photos of the HOPE team. So couldn't help myself. Okay, so the past few years I've been working on a post-overdose response team based out of DSAM at the General. And I'm going to explain the ecosystem of post-overdose response in San Francisco with the caveat that a lot of this is changing as funding streams change in the city. But this is also a source of data from one of the projects I'm going to present. So in San Francisco, when someone calls 911 for an overdose, they dispatch a paramedic, an ambulance there. And at the same time, there are community paramedics often riding along with a health worker who are similarly attach themselves to a dispatch for an overdose and get there often shortly after the main ambulance gets there. And when they get there, they talk to people about what happened. They ask them some questions, and they offer harm reduction services and linkage to treatment. They also they've started to offer buprenorphine in the field. Those people chart in a medical record, and referrals get sent usually the next day to a couple outreach teams, our team at UCSF and the POET team at DPH. And we have the goal of outreaching people within 24 to 72 hours after an overdose to see if they're interested in services or treatment of any kind. And this is work that we're winding down, but some of it's still ongoing through DPH. So I want to share 2 referrals so you can see what the data look like and what the situation looks like. And these are charted by a community paramedic after having seen someone post-overdose. I'm going to read it. Dispatch for an overdose. Upon arrival at the scene, found client sitting upright in gurney in back of ambulance. Client stated he thought he was smoking crystal meth. He was given 2 doses of naloxone prior to arrival. Client was not interested in harm reduction info, buprenorphine, or anything related to opioid overdose. Client stated that he tries to stay away from fentanyl and only smokes crystal. Client was explained, and here's a hypothesis that we're going to talk about on the research side, was explained that fentanyl is in a lot of meth on the streets, and the importance of having naloxone on him at all times, not using alone, and testing any substances he uses for fentanyl. So we're going to go into that sort of contamination hypothesis later. I'm going to share one more story, or referral. Client was engaged at the hospital after he was brought in by ambulance due to unintentional narcotic overdose. Stated that he never uses opiates and thought he was smoking crack as he has for 50+ years. Stated that he has never overdosed and never been given naloxone. Accepted a resource guide, harm reduction kit, naloxone, but refused follow-up. Stated he's staying at the navigation center. So this is someone experiencing homelessness. And both of these stories, I think they hit really hard. I'm thinking the second account here is someone who sounds like has been using has been using crack cocaine for 50 years. This is probably someone in their 60s or 70s, and has never had an overdose. So what is going on here? What is going on? And it makes sense maybe that they didn't want services if they're offering services for opioid use disorder. So we started asking some questions, and I should say we get referrals that look like this every single day. So and not all overdoses in San Francisco are even coming to medical attention. So this is happening in San Francisco every single day, alongside overdoses from people intending to use fentanyl who experience an overdose. But reviewing these, we had questions about how big of a problem was this, and how does it happen, and then are we doing the right things to prevent it? And I'll go over my thoughts on some of these things. But first, let's zoom out. So in San Francisco, fentanyl is the major driver of overdose mortality. It's the same story nationwide. Fentanyl is sort of the causative agent in overdose. The methamphetamine, it's a more complicated story about its role in methamphetamine and fentanyl involved overdoses, but fentanyl is the main driver of mortality. San Francisco, historically, the street opioid market has been black tar heroin dominant, as would other places in the West Coast. But fentanyl arrived on the scene and has largely replaced black tar heroin as the primary opioid available. And what's interesting and somewhat unique to San Francisco is that fentanyl is sold as fentanyl. There are other contexts where fentanyl is sold as heroin, but fentanyl is sold as fentanyl. And there's been an interesting transition that multiple researchers locally have documented of people transitioning primarily to smoking. There are still plenty of people who inject drugs, but with the arrival of fentanyl, a lot of people transition to smoking. And stimulant co-use is the norm. So we see this in the data, and when I see people at intakes in clinics, anyone who's a daily fentanyl user, almost every single person is also using methamphetamine daily. And that's for complicated reasons that I think may largely relate to how sedating fentanyl is, but this is the norm. The converse is not necessarily true. There are plenty of people who use stimulants who avoid opioids at all costs. And by stimulants, I'm referring to cocaine and methamphetamine. So crack and powder cocaine and methamphetamine. So most of the data that we have on overdose are from people who've died of overdose. And so these are post-mortem studies where you can look at what substances are found in their system after they passed. And you don't get information about what they intended to use, what they purchased, what they thought they were using. You just get information about what's there. With that in mind, I am going to present some data on overdose mortality. We're in the middle of what Dan Ciccarone, faculty at UCSF, has called the fourth wave of overdose deaths, which is a wave of deaths characterized by fentanyl stimulant co-involved mortality. And you can see the prior waves. I'm not going to go into them. And Friedman and Schover took this framework, the fourth wave, and they did what's a really nice thing to do when you have a lot of data, national data, is they drilled down and did an intersectional analysis, and they found, and I'm interested mostly in their analysis of the Western states, they found that stimulant fentanyl co-involvement in overdose deaths was more common among Black or African American individuals and more common in people in the older age brackets that they had. And coming back locally, we see similar things to the national epidemiology where opioid and stimulant co-involvement in overdose fatalities is the norm. So what do we know about unintentional fentanyl use? I think this is something that you see on billboards in some cities, on buses, you hear it in the media. Unintentional fentanyl use has largely been studied in the research context in the setting of fentanyl adulterated or substituted heroin or opioid pills. So this is there's been a lot of good work done that was characterizing the evolving illicit drug markets when fentanyl came to be introduced into heroin. And also, opioid pills like people call them perks or M30s that increasingly are consist of primarily fentanyl. Relatively less has been done looking at unintentional fentanyl use, and that's this acronym here, among people who use stimulants and try to stay away from opioids. We've seen multiple reports, and I cite a couple of them from MMWR, of overdose clusters, for example, among a group of people in New Haven who bought cocaine, what they thought was cocaine. So there are these kind of like overdose outbreak reports of this happening, people having opioid overdoses when they think they're using other substances. And then there's been data from community drug checking programs, which are a lot of harm reduction agencies have the capacity to test substances. So people bring in samples, trace samples, or they can have even paraphernalia tested when people want to know the content of their drugs. And in different locations, they have found that people bringing in samples sold to them as stimulants, a small percentage of them do contain fentanyl. We don't know in what proportion, and the same goes for DEA data. There's data that show that from seizure of stimulant samples, some of them do have fentanyl quote unquote contamination. And there's been emerging qualitative work that shows that people who use drugs are concerned about this. That includes both people who use opioids and would rather not use fentanyl, and people who use stimulants. And I'll dig into some of this more recent work later on. Locally, we've had a question from clinical experience about whether unintentional fentanyl use among people who use stimulants is exacerbating pre-existing disparities in overdose mortality in San Francisco, particularly Black-white differences in mortality. And so, as I mentioned, to get at intentionality, you can't look at decedents. You can't look at people who've had a fatal overdose. You have to find people who've had a non-fatal overdose. And so this first study that I'm going to present is one where we did just that. So we came in with these questions. What proportion of opioid overdoses can be attributed to unintentional opioid use? And do reports of unintentional opioid use differ by race and ethnicity? And then is this a one and done phenomenon or do these recur? Is this a population at elevated risk of mortality? So we did a series of public health investigations. The first one I'm not showing is actually very focused or chart review based on a group of colleagues from the Department of Public Health. And I looking over some of these narratives just to say, does this appear to be a big enough problem that we should look into it more? And that investigation, those kind of series of meetings quickly said, yes, we need to look into this more. And so we launched a more systematic public health investigation. This involves sampling overdose responses from it's the SORT team, which is that that team I showed the workflow for outreach over a few months in 2022. And the advantages of these narratives are they happen really close to the incident. There's very few cohort studies that would be able to capture an overdose and get someone's account of it, within minutes to hours after an overdose. So the data are very close to the source. However, as you can imagine, there are complications. People aren't going to want to tell a paramedic leaning over them after an overdose everything, but we do think the data were useful. So to do this analysis, we developed a case definition for overdose, and we abstracted what people told the paramedics that they thought they were using. There were 448 records in that time period we selected. 221 of them met our case definition for opioid overdose. Probably almost all of these were actually opioid overdoses, but we applied this fairly strictly to get at that. And then 171 of those people engaged in a discussion with the paramedic about what they had used. So what did we find? Well, we found that 42% of people who had an overdose, so this is an overdose where they were obtunded, the respiration was decreased, they got naloxone. So had a medically attended opioid overdose. 42% of them said they weren't intending to use an opioid. They thought they're using something else. So this is sort of a shocking number because it doesn't match at least in the narrative, how we think we're talking about opioid overdose prevention. We're thinking about the treatment of opioid use disorder. We have great medications for that, and decades of evidence in how to do that better and evolving. But this is something else. And so among those people who said they weren't intending to use opioids, what were they using? They're almost all using stimulants: methamphetamine, crack cocaine, powder cocaine. So most of this unintentional opioid use is happening among people who think that they're using stimulants. And just the background to align with what I told you about the epi, among those people who said they were intending to use an opioid, what opioid is it? It's fentanyl. 98% of people who had an opioid overdose and thought they're using an opioid had been intentionally using fentanyl. So what I'm trying to say here is, like, heroin is becoming a bit player in this story. And getting at our question about demographics, we did find that unintentional fentanyl use overdoses were more likely to be reported among Black individuals and older individuals, which aligns with the clinical anecdotes. And then I just want to show a little bit of preliminary data. This is something we're working on now, is linking a similar data set to vital statistics to understand, again, is this a population that has a behavior occur, has this health outcome, and then is able to somehow change their exposure to risk and it never happens again, or is this a population that remains at elevated risk? And so we linked a set of referrals. We did a similar thing. We coded intentionality of use, and we linked this to mortality data. It's all cause, not overdose specific right now. And we found that, first of all, the mortality rate in this cohort is astronomical. So 10 deaths per 100 person years. That's 1 in 10 people followed for a year or responded to by this team are not alive at the end of the year. And we found that although it appeared to be higher among people who said they were intentional fentanyl users, it's still profoundly elevated among people who reported unintentional fentanyl use. And so this we take as preliminary evidence to say that this is not a one and done phenomenon. This is a population that remains at elevated risks and merits further investigation and concern and response. So some open questions here. Some of you may be thinking this, like, why would someone, again, overdose is a traumatic experience. People have a range of responses to it. People can be very sick after getting naloxone. So why would they tell the paramedic the truth in this setting about what they're using? What's interesting is that you would think that, so methamphetamine and cocaine are illegal for use in California. So, and as is fentanyl, but there is an extra stigma around fentanyl because you can't walk anywhere without people saying fentanyl kills. And so there is good reason why people would underreport intentional fentanyl use. And so the question I have here is not whether or not there's bias, but like, what if half of these folks actually were intentionally using? That still means 20% of non-fatal overdoses are from people intending to use stimulants. So even if half of this were due to bias, it's if 1 in 5 overdoses in San Francisco and maybe on the West Coast are due to this phenomenon, that merits further investigation and concern. So, and what was interesting is we didn't know what to do with this because we have colleagues in the harm reduction space who do drug testing in San Francisco, and these are not published data, but what we've heard are that so these are site-based drug checking programs, again, where you bring a sample of your drug in, often for FTIR testing of what's in it, and they'll list out the contents of the drug. This is better than fentanyl test strips. What they've found is that people who come in with a drug that was sold to them as a stimulant, cocaine or methamphetamine, none of them are testing positive for fentanyl. With testing that is fairly accurate. So, and they said that they you know, the last time I heard them present, like they said, the only time they got a positive fentanyl test is when people pulled a rock out of a container that had multiple drugs in it. So there was obvious like possibility for physical contamination. So how do you get that result from community drug checking and this result from talking to people after they've had an overdose? And for better or worse, that requires talking to people and going out there and not reading records. And so that brings me to the next study, which is a qualitative study looking at unintentional fentanyl use among people who use stimulants who experience an opioid overdose. So, and it's a little in the weeds here. We're talking about survivors of opioid overdose who do not intentionally use fentanyl or any other opioid. These folks were primarily recruited from the post-overdose response team, where we have records that, you know, someone had a real overdose. You know, they had naloxone administration after having, you know, an overdose. And we had a couple of people that participated through a peer referral and one person from the hospital. And these were conducted over a year, wrapped up last summer, and we've been analyzing the data. When I set out to do this study, I had questions mainly about intervention. So what do these folks want? What do they need? What do they think about my various ideas about what might prevent this? And as we started interviewing people, we realized that the richness and the complexity was actually in how people ended up with fentanyl in their system in the first place. And so we iterated the interview guide to make sure we got at a very rich narrative of what happened that day. And we still asked about attitudes toward various interventions as well. We recruited a diverse sample with respect to gender, race, ethnicity, and stimulant of choice. We had intended to purposely diversify the sample. We didn't have to. This is fairly reflective of who's experiencing unintentional fentanyl overdose in San Francisco. And I will say, because of the referral source, our UCSF outreach team was contracted to serve people housed in mostly in the SRO environment. So almost everyone was housed. And out of this, we were focused first on understanding sort of the physics of exposure. What is the mechanism where fentanyl ends up in someone's body who's not looking for it? And we, from this analysis, we broke use down or exposure down into three phases: the procurement of the drugs, the storage of the drugs, and the preparation and use of the drugs, to think about where along this pathway fentanyl was introduced. And there were several emergent themes that I'm going to present that kind of cut across this, and they get at the routinely employed practices that people use to protect themselves, and why on the day of their overdose either they didn't deploy that practice or it didn't work. I'm going to present a lot of narratives here. I am trained as a quantitative epidemiologist, but this was a very, it was incredible to hear the kind of detail people gave. And I want you to listen to them both for the physics, again, of how did fentanyl end up in someone's body, and for the social context. So these are happening at the individual level, the interpersonal, and the social structural ways that people are getting exposed to fentanyl. And we'll talk about that explicitly, but I want you to hear these narratives in both ways. Let's talk about procurement. This one we call found a bag. one of my friends found a bag of what we thought was coke in the bathroom at my SRO. And so, I hit it. It seemed like it started to crackle, like crack. But then all of a sudden, that's the last thing I remember. So this is someone with friends who found a bag, looked at it, thought it was cocaine, had some various sensory cues about what cocaine might look like. And it didn't work. And here's another common, pathway: supplier mix-up. The person that I got it from when I OD'd, he didn't know that it had fentanyl. So I called, I said, my baby daddy said you gave him some fentanyl. So this person called the dealer and said, hey, like, what happened here? The supplier said, I might have. I didn't do it intentionally because he sells fentanyl too, and crack and weed, but he didn't know he'd mix it up. So I guess it was an accident. I called and told him what happened to me, and he said he didn't do it intentionally. If he did, he apologized, but he also OD'd. So this is interesting, and this is something we heard from folks, and I'll present another ethnographic paper that just came out by a team in Riverside, where people who are dealing drugs are often passing out small bags of it like this, and they may have cocaine in one pocket and fentanyl in another pocket, and it's possible that at the level of distribution or preparation that they're giving the wrong thing. And this person clearly has a relationship with their dealer. And they apologized here. Let's talk about exposure at the level of storage. So, and this is fentanyl stored alongside stimulants. Just gonna take 1 second. So this young woman said, my boyfriend does fentanyl. So he made one syringe for himself and one for me. He prepared the syringes to be used for injection later. And so we got into an argument because I was mad because he couldn't find a vein on me for injecting. She's using his help for injecting. And so we separated, and I was going to go and have somebody else do it that I could trust, that could hit me. And so I took both points with me. She took both syringes and went out, not realizing that one might be different from the other. She found them on the bedside table where he had prepared them, sitting next to each other. I don't even know why you put them together. You know what I'm saying? He put them together. I carried them in a little pencil case. And so I got to my friend. He hit me perfectly. And she knows right away that something's wrong. I knew I messed up right away. Like I was like, uh-oh, that might have been the wrong one. And there's actually well, I'll read this and then I'll comment. But she says, my boyfriend at the time, usually he would do it all the time, inject her. So there's a robust literature, mostly from the heroin era, of assisted injection. So people who require assistance injecting, often happening in hierarchical relationships. And this has been studied in the context of mostly women being unable to enact HIV prevention strategies because, or the extra vulnerability added when they're in a relationship where they rely on someone else to inject them. So she's my boyfriend at the time. Usually he would do it all the time. He'd never miss or anything like that. Just jing, jing, get it done. You know what I'm saying? And I asked, you also hit yourself? And she said, no, I can't hit myself. I don't know how to. So this is someone who injects methamphetamine many, many years and is unable to inject herself. So I hope you're hearing here both the sort of physics, we have the mix up in the pencil case, and then the social structural context. Now let's talk about equipment, smoking equipment, paraphernalia. This was a very animated interview. He yelled the whole time. Said, yeah, and he put fentanyl in a separate bong. And it was the same fucking looking bong. And I just picked it up. I took a bong hit of it and I woke up at fucking St. Francis Hospital. Like, this is the fentanyl and this is the speed one. And I'm like, whatever. I was playing drums and I just grabbed the wrong one and just, that's all I remember. So this is someone who, again, we have people smoking from a similar device. And also I'll say socially mixing. So someone who avoids fentanyl, playing in a band with someone who smokes fentanyl, and the drugs are in the same space. And similarly, here's a quote, it was the same pipe. The reason this happened was because I have friends that do fentanyl, and my stuff got mixed up with their stuff, and it was in the same kind of pipe that I was using. And I didn't know that, so I overdosed because I used the fentanyl instead of the meth. we were sitting next to each other and all this stuff was just like on the floor and they looked the same. So it was the same pipe. So this is also, we're talking about social mixing of people who use drugs, which I'll say that in various environments, neighborhoods, and chapters in history, people say that like people use stimulants whose opioids are like oil and water. They stay apart. There's social hierarchies and politics of drug use that people use to hate on each other. We did hear a lot of stories about social mixing of people who use both substances. And then this was a darker narrative that came out multiple times, both in people speculating secondhand and among people we talked to who had firsthand experience of this from their overdose. It's intentionally giving fentanyl to others. So this one is called Trying to Steal. She said, I was smoking. I let this guy use my pipe and he put some fentanyl on there. I didn't know what it was, but I started feeling kind of funny. Next thing I know, I woke up, I was in an ambulance, took me to the hospital, they checked me out and everything. So basically what he was trying to do was steal my credit cards, and he took my food stamp card and my ATM card. And the social context here, this person is unhoused, is sharing smoking equipment. And I'll comment on this because this is, we got consultation around these findings with colleagues because when you're talking about fentanyl or any drug, all this stuff has the potential to be very inflammatory. And so, I talked to some people who said like, alcohol has been used for generations to exploit other people. Unfortunately, like this is what humans do in some cases, particularly in cases where there's severe resource deprivation, where people are stealing. Someone has stolen an unhoused woman's food stamp card. So poverty is also underlying social context here. And then this is a big cross-cutting theme, and I'll show some photos after this. But fentanyl and stimulants these days, are indistinguishable. And sensory identification was something that a lot of people use. They look at their drugs to see if something looks off, to see if they look like what they think they are. They also smell them, they taste them, they listen to how they sound when they smoke. This person said, I forgave them. I forgave that person that gave me the fentanyl I overdosed on because he didn't know. Because he was buying fentanyl, he didn't know because he was buying fentanyl from the dealer, saying it was, because you can't decipher between meth and fentanyl now because it's all powder form. I mean, it's not all powder form, but this is a core issue. Another person said, it didn't even register to me that, oh, this might be fentanyl, because the bag that I had my methamphetamine in looked exactly like the bag that my friends had their fentanyl in. I thought fentanyl was like pinkish or it was like multicolored or whatever. And it was the same color as mine. It looked like it was just a powdery white substance. And that's why I thought it was the same as, I thought it was my Coke. And so I will say that prior to the arrival of fentanyl on the scene, it was reasonable to assume that if something was white, crystalline, powder, chunks, that it was not an opioid. Because in California, black tar heroin is the predominant opioid. And so people could reliably look at their drugs and say, this is not an opioid. This is brown, sticky, crumbly. This is probably an opioid. And so those assumptions that people have no longer hold. And just for, just to make the point, so we have here on the top left, that's crack cocaine. Below that is fentanyl. In the middle top, that's meth. On the bottom is fentanyl. The top right, that's meth. And the bottom right, that's meth. I didn't even show the powder forms, like white powder forms, which is for powder cocaine and fentanyl can be totally indistinguishable. So, and I think there's a little bit of people have this narrative. There's a whole, sort of toxic campaign about like fentanyl life. I don't know if you saw these posters where they're making the fentanyl all different colors to get the children. And so I think people also, we wondered when we heard these stories that people also absorb some of that, thinking, oh, fentanyl is like rainbow colors. Fentanyl doesn't look like methamphetamine. I don't want to just blame that campaign, but we wondered that because you see these posters up in the Tenderloin. So People consistently said fentanyl is unavoidable. The market is saturated. You can get meth, but you can only get fentanyl. Like you can't get black tar heroin anymore to save your life. And not that I'm looking for it, but my friend was talking about that the other day. And he said he was going to try to get that for someone and they couldn't find it anywhere. The market has been completely saturated with fentanyl. This is no news to any of you who, live and work in San Francisco, but I just want to make that point. And then there's no safe space to use. So this person says, those people who use fentanyl, they're not really my friends anyway. And I'll say, like, there is, I talked about social mixing, but there's also social distancing and stigmatization among people who use stimulants who don't use opioid switching. They're not really my friends anyway. It's just that sometimes my friends who are friends with those people will show up at my door with them. And that can be uncomfortable. It's hard to turn them away. But I think I'm strong enough now to say, I had an overdose and I don't allow fentanyl in my apartment. That's it. So your friend has to go. So this is someone talking themselves up to say no. Their personal strategy for reducing exposure is to not let people in their apartment who they think use fentanyl. I'll say that we heard multiple stories. I don't know if I have more quotes coming up on this, but of people who were trying to help out someone that they knew, an acquaintance, a friend who was unhoused, letting them into their space, a space that they normally don't let opiates into, letting them into their SRO because it was, they were in a hard spot socially or because of homelessness, and then ending up having a mix-up because of that. So there is sort of like a moral reciprocity, happening here. People are caring for each other, and that is also a part of the story of why people are getting exposed. But coming to the end of the quotes from this qualitative study. So let's talk about poverty. And she really lays this out from start to finish. She says, using math also has to do with the kind of lifestyle you end up in. When you have to pay $1,600 in rent for an SRO, $1,600 in rent, and you only get $900 a month for all your expenses. Everything included in your SSI isn't enough to survive on in San Francisco. There's no way. So you have to supplement your income somehow. And unless you steal or you deal drugs, you can get a job and not get caught by SSI, you're going to end up doing what I did, which was prostitution. And so it's really challenging to stay out of crime when you can't have a W-2 or lose your benefits. So that's the context that this person is operating in. And here's what happened with her overdose. Me and this guy were just talking, smoking a joint. And he says, and I think this is a client, oh, I have some cocaine. Actually, I'm not sure if it's cocaine or fentanyl. And I looked at it and I said, I think it's cocaine. And I've been up for a while on meth, and so it wasn't working for me. I was like saturated. I couldn't really do any more of that. Like, yeah, I really wanted to snort a line of coke. She wanted it to be cocaine. And I had to get rent money too. So I was trying to stay awake, okay? So I snorted a big line of it, or like the size of my pinky nail, of cocaine. Well, what I thought was cocaine, and it turned out to be fentanyl. And so I think this, this story that she shared with us illustrates points both on like everything from the material aspect of this, like how, the substances look, to the urgency of use under, subsistence, like sex work in a high cost of living city. And I have another quote from her where she said, it looked just like, she called it Bolivian flake. She's like, looked just like Bolivian flake, like high quality cocaine that she used to use in the 90s. She couldn't believe that it was fentanyl. She was a very experienced person who uses drugs, had a lot of knowledge about the drug scene. So, we've tried to construct a theory, and this is a figure that one of our amazing CRCs, Elisa Samioa, made with Bryson, the medical student, and I, where we were trying to understand, I'm gonna see if my pointer works here. No, it doesn't. Let's see. So, we're talking about the physics here, right? Procurement, storage, consumption, but all these things happen in a broader context. They're individual factors. There's people's state of mind. I didn't show quotes in this, but often people are intoxicated with other substances when they're using, so mix-ups are more prone. And people do have individual level behaviors that they use to reduce their risk, but these often fail for various reasons. Drug use often happens in our interpersonal context, in relationships, in communities. And we talked about the gendered power dynamics here. And then underneath it all, or above it all, are the structural systemic factors. So there's poverty, there's racism, there's inadequate or expensive housing, an unregulated drug supply, and no safe space for people to go to use drugs where overdoses can be reversed. So we're working on the manuscript, and we're trying to tease out sort of the connections from these very material, physical aspects of risk to the broader social structural context. So what about contamination? We went in with this question about like, well, the drug checking data says like there's no fentanyl in the meth, but like everyone says there's fentanyl in the meth, and everyone thinks that. And you'll notice I didn't show any stories about like contamination. Most people after their overdose were like, oh my God, I just used fentanyl. They weren't like, oh, there must have been a little fentanyl in that meth. And again, then we don't know, we didn't test the drugs, but we found no single pathway to unintentional fentanyl use among people who use stimulants. Not clearly driven by contamination here. But that doesn't mean contamination isn't happening. This is a small slide, but other studies from other settings suggest that trace or low-dose fentanyl exposure is probably occurring among people who use stimulants. So in a paper I was involved with, in a secondary analysis of some banked biomarker hair samples from a cohort of men who have sex with men who inject methamphetamine, we tested the hair for fentanyl. And they found that 22%, small sample in LA, of these men tested positive for fentanyl in their hair, despite not intentionally using fentanyl ever. I don't have data from this about whether any of them experience an overdose, but and interestingly, another piece of data locally. So my mentor, Philip Coffin, has a trial right now looking at treatment of cocaine use disorder, and you have to have a negative urine screen for fentanyl, and they've had trouble recruiting because a lot of people come in saying, I use cocaine, I don't use opioids, but they're having a urine screen positive for fentanyl. And we have this alongside settings, studies in other settings that show that actually what people think they're using is a pretty good predictor of what they are using. While drug checking locally hasn't found fentanyl in stimulant samples, drug checking in other settings throughout the country has. And interestingly, the nationwide study that pooled results from harm reduction sites that do drug checking across the country, they found that almost exclusively they found like quote unquote contaminated samples in drugs in powder form, so powder cocaine and powder methamphetamine, and they didn't find it in crack cocaine and like meth in crystalline form. So what's going on here? Are people getting trace exposure to fentanyl that is not clinically significant? We know some people are having frank opioid overdoses. Is there so-called sleepy meth? And we hear about this, maybe you've heard about it clinically, people saying that the meth just doesn't feel right. Maybe there's fentanyl in it or something else. And there's probably a spectrum here. It's probably all true. So this really beautiful ethnographic piece just came out from UC Riverside by Syvertson. And she documents a range of accounts among people who use opioids and people who just try to use stimulants, where people talking about sleepy meth, so the meth didn't feel right, people using what they think is methamphetamine and then vomiting for a couple hours, which can be characteristic of significant opioid exposure in someone's opioid naive without overdose, and then overdose, which is what we've talked about. My colleagues at Brown had an interesting take on this. They had a question about how is this happening? Because the narrative on the street is also that international drug trafficking organizations are poisoning people. They want them hooked on fentanyl. They're putting fentanyl in the meth. They're putting fentanyl in the coke. So they had an interesting study design. They went into the prison in Rhode Island, and they recruited people who've been recently incarcerated for a drug trafficking charge. And they asked them, what do you think about this? They said, don't tell us about your personal experiences. We don't want to incriminate you. Tell us just in the abstract. Everyone talked about their personal experiences. And they said, this is not happening. These are people with intimate knowledge of the drug supply. These were not people who were like, quote unquote, like street level dealers primarily. They're saying that intentionally contaminating the drug supply doesn't make any sense for economic reasons. And it likely is from sloppy preparation. So maybe not wiping down the scale between measuring out drugs, which could be a way that someone gets trace exposure enough to have a urine screen positive for fentanyl without having a clinical syndrome, or accidental mix up at the point of sale, which is what we talked about. So interesting study design, go to the source. All right, I'm gonna give a couple conclusions about this work, and then we'll talk a little bit about prevention in the last piece. So I hope I've made the point. Unintentional fentanyl use is a common contributor to overdose in San Francisco. There's a lot of pathways to use. People do have a range of practices that they use to reduce their risk, and some of these don't work in the fentanyl era. And then I'll just say, zooming out, changes in the drug supply can have surprising and devastating consequences. So mostly we think about fentanyl being so dangerous because it has extremely high and unpredictably varying potency. But actually, what has happened is that stimulants and opioids can no longer be reliably distinguished visually in the fentanyl era. So this is another aspect in which fentanyl is what the antiquarians call the historic foe. And when we have changes in the drug supply, they arrive in the environment that we build. So if they arrive in a landscape that's been shaped by inequality, they're going to exacerbate that unless we actively, take steps to counteract that. And so, this is another piece that we're trying to bring out from the data. But we know that, some communities, and particularly communities of color, have different access to harm reduction services, and those service points can often be the source of information for changes in the drug supply, and also for good reasons. Syringe service programs were located in areas where people were injecting and communities where people were injecting, and there are now communities of people who maybe all of a sudden are needing more overdose prevention education. So pockets of people use stimulants. Who've kept themselves safe, as the gentleman in our first slide talked about, for 50 years until this happened. Some of the things we talk about require massive policy change or political will to address. So safe spaces to use drugs where overdoses can be reversed. Here I'm talking about overdose prevention sites. People who are using alone. If you use methamphetamine or you've used crack cocaine your whole life, there's no reason to think, oh, never use alone. Never use alone is a strategy for people who use heroin. A lot of people say, I don't want to be out there with these young, crazy kids. Like, I want to be alone in my room using crack cocaine. They just don't want to die. And so overdose prevention sites are one thing that people have talked about if they're made acceptable to people who smoke drugs and not just inject. And where if someone has an overdose, the potential for them to be reversed is there. And then we need safe and supportive housing. I'll say, I'm going to quote or paraphrase Garth Mullins, who's the author and podcast host of Crackdown. He says that when they started this war on drugs, people were smoking opium, right? Look how far we've come. And so a focus on prohibition and policing may continue to drive unpredictable toxic changes in the drug supply. So I'm not saying enforcement of global drug trafficking doesn't have a role, but unexpected things, or after 100 years, we should say they're expected, can happen in terms of how market pressures and enforcement pressures change what's being sold. And in the meantime, a lot of us are out there talking to patients who've had this happen. Shout out to my colleagues zooming in from the general, for those who made the long drive. This is happening every day in San Francisco, and we do need something to do with individuals while we're waiting to change the world. So here are my thoughts on prevention. I hope the NIDA Council is also listening. So let's talk about a very simple model. For someone to have an unintentional fentanyl use overdose from this population, they have to use what they think is a stimulant, they have to get exposed to fentanyl, and then they have an overdose. And I'm thinking about prevention in these three places for individual level prevention. So one option might be to try to target decreasing the frequency of use of stimulants, or reducing the use of substances thought to be stimulants. And what do we have for that? We've thought about linking people to care. We have contingency management, and both of the substance use disorder treatment clinics that I practice in. There are also off-label medications for craving and use reduction, mirtazapine, extended-release naltrexone, and bupropion. And then there's the concept of safe supply. The evidence is mixed, but not ignorable, that prescription psychostimulants for people with stimulant use disorder may have a role in this. And that debate is played out mainly does prescribing, stimulants reduce illicit stimulant use? But now there's a question of would that have an overdose prevention benefit as a sort of safe supply? No data on that, obviously. Then what about preventing exposure, acquisition and exposure? I usually don't point to structural problems and say that the answer is education, but I actually think there's a role for education here, because a lot of people don't have awareness of the ubiquity of fentanyl, the unreliability of visual cues, and there are potentially behavioral strategies for reducing risk. And then the mainstay tools that we use, these are the things we give out every day, although even this has become politically complicated these days. Fentanyl test strips for people willing to use them and who have a stable place to use them. Pipe labels, so some of the syringe services programs, or I should say harm reduction centers, because it's not all syringes anymore, will give out colored pipe labels so people can mark their pipes, so that people who use fentanyl aren't mixing it up when people use stimulants. And then I think there's an argument to be made that safe smoking supplies, which in San Francisco, people want glassware. They want bubble pipes and straight shooters for crack cocaine and methamphetamine. And glassware, there are some parallels to be drawn with syringe exchange. If people are using other people's pipes, there's a chance for mix-ups. And Dan Ciccarone published a paper, an ethnographic paper in San Francisco last year called something like Fentanyl Cultures. They go in elaborate detail with photoethnography about the ways that people smoke fentanyl in San Francisco. And there is a lot of residue in the pipes that is considered to be extremely potent. And so there's a chance that sharing smoking equipment actually has the potential to expose someone to fentanyl, even if they're, it's an empty, quote unquote, empty smoking device and they put methamphetamine in it. So I think there are parallels to be drawn for making this argument for safer smoking supplies. We don't have, they've asked for more robust data, and in the current local political context, there's been some back and forth about how and when you can give out smoking supplies. But the more research needs to be done here. And then there's site-based drug testing. For people who are patient enough, take their drugs each time they get a new batch from their reliable dealer and go down on whatever day the truck is in the right place or the fixed site and test their drugs. What about after someone has the fentanyl in their possession unknowingly? In the heroin era, they talk about a test dose. You can always use more, you can't use less. So using a very small amount. I just talked to someone in clinic yesterday. I used 68, never had an overdose. And he said, well, I just use a little bit first and see how it is. My colleague in ID, Dr. Appa, has a trial right now looking at extended release naltrexone as overdose prophylaxis among people who use stimulants. So naltrexone, it has this modest evidence base for reducing cravings in combination with bupropion for stimulants, but actually, it's an opioid antagonist. It blocks the effects of opioids. So there's a reasonable basis to assume, and people have been using this clinically, one-off, that for people who use stimulants who are open to getting a monthly shot, this could be a way to reduce overdose risk. And so she's just started recruiting for this. And then what about after someone's been exposed? Has had an overdose. So we need to make sure we can reverse overdoses. And that means naloxone distribution and education programs. We're in a city where we've done a damn good job of getting naloxone everywhere. And yet I'm seeing people who've said, you saw the quote, no one's ever given me naloxone before. Naloxone, why would I carry that? I use cocaine. I use methamphetamine. And so we still have work to do, even in a city that I think has done really well on this front. We talked about never use alone and how that resonates and doesn't resonate with some people. And we talked about overdose prevention sites. So a lot of the fatal overdoses in San Francisco are happening behind closed doors with people who are alone. And so when you're thinking about prevention, a lot of these pieces don't fit in. So, these are not overdoses where a bystander could have intervened to reverse the overdose. And so, there's a lot of attention being paid to how to help people who are in SROs using alone, but it's a hard issue. And it's partly a facet of social isolation, and particularly for older people who use drugs. Okay, so we have a grant awaiting council review that we propose to do a multi-component behavioral and linkage intervention for people who use stimulants, where we would follow them do timeline follow-back to ask them whether they had any overdose experiences, and also test hair for exposure, including subclinical exposure. And so the design is to randomize people to this Be Safe portfolio intervention, which involves linking people to care, along with a pre-existing academic detailing program that can coach providers in substance use settings about how to manage stimulant use disorder, a personalized MI-based overdose prevention plan. This is based on the reboot trials that were designed for the heroin era, but it's basically people have strategies that work for them, so it's finding out from them what works and building up their motivation and confidence to deploy those strategies, and then using text message reminders. And so this is a study that I would like to do. In the meantime, you know, we'll be doing whatever from this list we can bootstrap in clinical settings. All right, thank you all.
Hi, thanks. That was a really wonderful talk. I feel like that was a unfolding of like a public health mystery that I really enjoyed listening to, and it's great that you're doing this work. I'm an epidemiologist, so I'm stuck on the prevalence. And you'd mentioned the bias around reporting.
Yeah.
But I think there's also the selection bias of who wants to tell you what they've done. And it appears to me that if you wake up having a completely different experience than you thought you would have, that you might want to tell someone about that more so than if you kind of knew what you were getting into and like knew that that might be a risk, and then also had the bias of not wanting to tell someone that you were using. And I guess it just makes me wonder, is there a better source for this unintentional use data? Like, is it in ER records, or is it somewhere, you know, where there could be, you know, kind of another source, and also maybe a more regional or national source? I'm assuming no, but I thought I would ask.
Great question. Thank you. We've thought a lot about this. We've actually submitted 2 unfunded R01s to do a prospective cohort study because I really just think that the emergency room data are not good enough. And so I really think you need to follow people outside of a medical setting, check in with them every couple months, have them do timeline follow back. And that's what we had proposed to do, like more of an epi study with looking at hair samples as well. And we got, you know, some feedback was like, maybe this is just a San Francisco problem. And in the past couple of years, since we've gotten those reviews, like papers have come out that have shown that like this is not a San Francisco problem. The drug markets are locally specific, and then also that you should just move to intervention. So that's what we're trying to do. And we're hoping that we can get some of that epi out of this study if we're able to do it as well. But if you think of ideas for how to bootstrap this, I'm all ears.
Sorry.
Great, Alex, this was amazing, riveting, and so comprehensive. It was one of the best talks I've attended in all time. Really lovely. Yeah, keep talking. This reminds me, so I have a million comments. I'm gonna not try to hog the mic. Where are people hanging out? So for example, you talked about prevention strategies around education, and those posters on bus stations about multicolored psychedelic fentanyl are bogus. Like, how do you get the information to folks? Where will they best receive information about put a sticker on your pipe, which I think is so pragmatic and so sophisticated at the same time. So anyway, and just a little side note, it's like we're all told when you're a woman in college to like never, like always pour your own drink and label your red cup. And that works pretty well. So anyway, just wanted to comment on that.
Yeah, and I first of all, I appreciate the connection with alcohol again, because like this is not just a fentanyl problem. And how do we get the word out? It's challenging because the pros at doing this are people who use drugs, people with lived or living experience, and often those folks are at what would have been called needle exchanges, syringe services programs, harm reduction centers. And so those are the pros, like organizations like SFAF, for getting the word out. However, not everyone who uses stimulants accesses those sites. And so how do you reach people beyond that? You know, we have people who purposely avoid the hubbub and stay in their SROs. I mean, people also use on the street who are housed in SROs to be around other people in community and for overdose prevention purposes. But I'm not sure how you reach these folks. And I am thinking mainly because clinically I've seen so many older folks who purposely isolate and who are using stimulants. And the other bias of this is that we're talking to people who survived. So these are people who had their overdose reversed. So I also want to think about how do you intervene and get the message out to people who are using in situations where if this happened, they might not have survived. So I don't know. Willing to think about it.
Thank you so much.
Thank you.